Dear students, dear colleagues, we continue the psychiatry lectures on the University of Pécs, Hungary, delusional disorder and other psychotic disorders. This is the topic. We already had a lecture on bipolar disorder. We already had a lecture on schizophrenia. And now we turn our attention toward other psychotic problems. And the most important here will be the delusional disorders. But there are some other disorders we have to mention. The first I would like to mention is this illness, which is called schizoaffective disorder or schizoaffective psychosis. This means a kind of combination of bipolar illness and schizophrenia. In the case of schizoaffective disorder, there is a parallel coexistence of bipolar symptoms and mood symptoms and schizophrenia symptoms at the same time. And the other important diagnostic criteria, that delusions and hallucinations, so the schizophrenia symptoms last at least 2 weeks after the disappearance of the mood symptoms. So this is the other very important diagnostic criteria, that at least for 2 weeks, but typically for a few months, the schizophrenia symptoms, the delusions and hallucinations last after the absence of the mood symptoms. There are two subtypes of this illness. One is the bipolar type and the other is the depressive type. In the depressive type, the mood symptoms are only depressive symptoms. In the case of bipolar type, both poles, the manic pole and the depressive pole, is appearing in the symptomatology. Illness was described by American psychiatrist Keselin in 1933, and the lifetime prevalence of the illness is 0.3%. The treatment can be antipsychotics, mood stabilizers, and antidepressants, and it very much depends on the symptomatology. So if there are serious depressive symptoms, beside mood stabilizers, beside antipsychotics, antidepressants can be given. In the maintenance treatment, the most important are the mood stabilizers as lithium carbamazepine valproic acid. Antipsychotics, maybe antidepressants can be used, so a combination, an individual combination of the medication is important. Another illness is schizophreniform psychosis or schizophreniform disorder. You remember that in the DSM, for the diagnosis of schizophrenia, a duration of 6 months or more than 6 months is needed. So you can make a diagnosis of schizophrenia if the symptomatology with the prodromal and the residual symptoms is more than 6 months. In the case of schizophreniform disorder, the symptoms last at least 1 month, but less than 6 months. So between 1 month and 6 months. And the same schizophrenia picture can be seen in schizophreniform disorder. The illness was described by Langfeld in 1939, and the lifetime prevalence of the illness is 0.2%, so it's lower than the prevalence of schizophrenia. And the third illness in the DSM-5, which I would like to mention, is brief psychotic disorder, where the duration is from 1 day to 1 month, so less than 1 month. And the symptomatology is very much similar to the symptomatology of schizophrenia, as delusions, hallucinations, disorganized speech, which means primary incoherence, catatonia, or the grossly disorganized behavior can be seen. In these cases, the reactive means that many times stressors are involved in the etiology, and Jaspers, the great German psychiatrist, spoke about on this psychosis as reactive psychosis. In other psychiatric schools, different names are mentioned and used for the description of this brief reactive psychosis. For example, in the French tradition, buffet délirant is used for this. In the Scandinavian tradition, in the Scandinavian psychiatry, the term hysterical psychosis or psychogenic psychosis is mentioned. So in different textbooks you can see these terms which nearly overlap with the DSM-5 brief psychotic disorders. Excuse me. Okay. The next disorder I would like to speak about is the delusional disorder. or paranoid psychosis, but in the English terminology, delusional disorder is used. These are typically non-bizarre delusions if we follow the definition of the ICD-10 and the DSM-4. In the DSM-5, bizarre delusions are also can happen. So in the DSM-5 definition, bizarre delusions can happen in delusional disorder. Previously, it was a kind of diagnostic criteria that only non-bizarre delusions can appear in delusional disorders. But typically, what we can say, non-bizarre delusions are characteristic of this illness. You remember that bizarre delusion means which is impossible, which can never happen, that I have visited the Mars this morning. And non-bizarre delusions are delusions which can happen, but which are not true in the case of the patient. For example, that the police is after him, that somebody would like to kill him, or that the wife is unfaithful, and so on. So non-bizarre delusions can happen, but not true. Bizarre delusions can never happen. And in the case of delusional disorders, typically, most of the cases, non-bizarre delusions are presented. The definition of delusion is well known by you. It's an error thought which is connected to the patient's ego, and the patient is not able to be influenced to give it up. At least 1 month's duration is needed for the diagnosis. The history, Carl Baum was the psychiatrist who first introduced the term paranoia in 1863. Sigmund Freud, the psychoanalyst, had a famous case report, a case study, the Schreber case, where a psychological understanding of the paranoid mechanisms were introduced by Freud in 1911. Schreber was a psychotic judge who published a book on his mental illness, and in the end of the 19th century, and Freud in 1911 published a very famous case report on the interpretation of the Schreber case, where he introduced the mechanism of projection and the concept of unconscious homosexual wishes as a base of paranoid symptomatology. So Freud said in this book that unconscious homosexual tendencies are the basis of paranoid symptom formation, and projection of inner unconscious feeling outside is the mechanism which can be seen in paranoid symptom formation, that for example, the patient has an inner unconscious aggression, it is projected out, and the patient starts to believe that somebody would like to kill him. So this is what projection means in the terms of Freud book. You can see here projection of latent homosexuality. Cameron, an American psychiatrist, introduced the term paranoid pseudo-community, which means that in the development of a delusional disorder, it can happen that so-called pseudo-community appears, which means that in the delusion, people are involved who are not part of the patient's real world. So the illness, for example, starts with the feeling that with the delusion that the patient believes that the neighbors would like to kill him. And later, the patient can believe delusionally that the reason why the neighbors would like to kill him is that they are agents of the FBI. And the FBI is not part of the patient's life here in Hungary. So this is what paranoid pseudo-community means. The subtypes of delusional disorders are shown here. Erotomanic type, which is also called Declarable Syndrome. Erotomania is a delusion when the patient believes that somebody, a typically female patient, believes that somebody who is in a higher hierarchical position loves the patient. So, for example, the secretary believes that the boss loves her, or the student believes that the professor at the university loves her, and this is not true. This is a delusion, and this is called Declarable Syndrome or erotomania. It starts with a so-called honeymoon period. The patient is very much happy that that great person loves her. But after a time, the patient's feelings can turn towards aggression because the patient cannot understand why the supposed lover doesn't tell her that he would like to marry her, and starts to attack the person that, okay, I see that you love me, please tell it to me and marry me. And when the supposed lover, the person who is supposed to be the lover, says that, sorry lady, I do not love you and I don't want to marry you, something you misunderstood, then the patient love feelings turns towards aggression and can attack the person or the wife of the supposed lover. The second is the grandiose type, and the patient has delusions, grandiose content. The patient believes that he has a special talent, he discovered the treatment of cancer, or he has a special origin. For example, he is from a royal family, so this can also happen as a part of the grandiose type. The jealous type, the third type, or which is also called the Othello syndrome after the drama of Shakespeare and the opera of Verdi, where the patient suffers from the jealous delusions and believes that the partner, the wife or the husband is unfaithful towards the patient, and it can be also a dangerous delusion because sometimes it can lead to aggression or to homicide. Persecutory type, when the patient believes that somebody would like to harm him, somebody would like to poison him, somebody would like to do something wrong towards the patient, the police is after him, his flat is full of small microphones and cameras and so on. This is the persecutory type. And the last one is the somatic type, which is also called monosymptomatic hypochondriacal psychosis, when the patient has a somatic delusion that he has cancer or that he is seriously infected by a virus. And this is not true. And when the patient is shown the negative results of the examinations, for example, a negative CT scan on the chest, the patient says, it's not my CT scan, you don't want to show me mine because it's full of cancer tissue and you don't want to give me the diagnosis, the correct diagnosis. So the patient cannot be influenced to give up the hypochondriacal delusions in the somatic type. And there is a mixed type if these forms are coexisting. For example, the patient can have erotomanic delusion and persecutory delusion parallelly. Canadian psychiatrist Munro spoke about monosymptomatic hypochondriacal psychosis in the middle of the 1970s, and he said that this form, monosymptomatic one symptom, hypochondriacal, somehow this is a somatic type of delusion and psychosis. And Munro said there are three subtypes of this psychosis. It can be a delusion of body smell when the patient believes that he has a bad smell, he has a bad odor, and everybody is disgusted by this. The second is the delusion of infestation, which is also called the egg bomb syndrome or egg bomb symptom, which we have learned during the first semester, that the patient has a delusion that parasites are in his body or under his skin, or viruses infected him. For example, the patient believes that he is infected by HIV or coronavirus recently. There were two interesting publications which were recently published, one in the Psychiatry Research Journal and the other one in the Hungarian Psychiatric Journal, Psychiatria Hungarica, where patients developed a delusion, a version of the egg bomb symptom, that they were infected by the coronavirus, and it was not true. They had negative PCR results, but they couldn't give up the delusion that they are coronavirus patient. And these are very interesting recent changes in the symptomatology of delusions. And the third one is delusive dysmorphophobia, when the patient has a delusion that his body has a disadvantage. For example, her breasts are too small, her nose is too big, and the patient cannot be influenced to give up this idea. There are two symptoms I would like to mention as the delusional misidentification syndromes. This means that somehow the patient has problems with identifying identification of other people. In the Capgras phenomenon, in the Capgras symptom, or in the Capgras delusion, the patient believes that somebody who looks quite the same as the original person is not the same, but replaced by a double, replaced by an impostor. For example, the patient believes that the mother who looks quite the same as the original mother is not the mother, but an impostor, a double, who was put instead of the original mother. This is the Capgras phenomenon. The Fregoli phenomenon, Fregoli's delusion is the opposite, when the patient says that somebody who likes quite different from the original person is the same person. So the patient says, this woman who looks quite different than my previous girlfriend is my previous girlfriend, who is quite different physical appearance, but I somehow feel, I somehow know that they are the same. So this is the Fregoli phenomenon or Fregoli delusions. They are opposite to each other. The Capgras symptom can be mentioned that this can be dangerous because sometimes these patients are so overwhelmed by their delusions that they can attack the impostor, the double, or can kill the double. And there are some case reports, there are some case series, and there are some epidemiological studies where Capgras symptom was seen as a cause of violent and homicidal behavior in the case of psychotic patients. For example, we have published a case report of 2 patients in 2019 where patients killed their family members, killed their parents. These were parasites because they believed delusionally that the parents were replaced by doubles, impostors. So the Capgras phenomenon is a dangerous symptom. You have to be very cautious with these patients, and you have to build a good therapeutic alliance. Long-acting injectables are many times needed for these patients because if they are non-adherent with treatment, then the overwhelming delusion can be dangerous. The treatment of delusional disorders are psychotherapy and antipsychotics. Antipsychotics should be used in these illnesses because these delusions can be very much intensive and very intense and should be reused. And psychotherapy is important because many times they are understandable unconscious moments in the symptom formation. And this should be dealt with psychotherapy, so it's important. The shared psychotic disorder, or with the French term folie à deux, which was described by Lassagne and Faré in the 19th century, should be mentioned. This means that there is a dominant patient who is the primary patient, who is a chronic psychotic patient, for example, schizophrenia patient or a schizoaffective patient who has a delusion, and there is another person who lives closely with the psychotic patient, who after a time shares the psychopathology, who after a time starts to believe in the same delusion that the primary patient, the dominant patient, believed in. So, for example, the primary patient who is a schizophrenia patient believes that the neighbors would like to kill him. And after a few years or few decades, the submissive patient who lives together in the same flat with the primary patient, who is, for example, a sister or a husband, starts to believe in the same delusion that, yes, the neighbors would like to kill us. And this is called shared symptomatology. Mainly delusions are shared, but it can happen very rarely that hallucinations or conversive symptoms are shared, but what we have to know here is the shared delusions. Separation of patients, hospitalization, and antipsychotics can solve this illness. There are some so-called culture-bound syndromes, as AMOC, which is an outburst of aggressive behavior, typically in India, or the Koro, which is in the Oriental countries, can be seen. It's anxiety that the penis will recede into the body. It can be an anxiety with an insight on the anxiety, then it's not a delusion, but it can have a delusional form, and the patient delusionally believes that the penis will disappear. Kuvad, psychotic kuvad, when there is a pregnant woman and the husband develops psychosis in in connection with the pregnancy of the wife. P-Block2, which is a psychomotor extreme agitation, extreme excitement in the case of Eskimos. And Vitigo, which means a psychosis among Indians in North America, that they will transform into Vitigo, a giant monster. So Vitigo is the name of a giant monster, and the patient has a kind of delusional idea around this. And this short summary, I would like to finish this lecture, and this was a kind of summary of other psychotic disorders and delusional disorders. So thank you for your attention.